Good morning, class. Today we're going to be talking about ethical issues in nursing management. We pretty much covered some of that when we went over management and ethical issues with our psych lectures. So a lot of these terms I will not be going back over and reviewing with you all because you all should know those. Just bring it over from what we discussed in psych. But we will go in a little bit more in depth when we talk about ethical issues when it comes to us managing the care of our clients. So our objectives are going to be define terminology, which I told you we pretty much went over the same terminology the other day in class. We're going to analyze personal values that influence our approaches to ethical issues and our decision making. Our ethical issues and how we view things and our values do determine how we want to take our clients and maneuver and decide if certain jobs are for us. So we're going to talk about that and discuss that. We're also going to discuss the role of the nurse in the ethical issues of healthcare. So when it comes to labor and delivery, when it comes to abortion, when it comes to death, suicide, any of those things, ethically, you need to be able to know how to maneuver and to handle those things. Identify controversial healthcare issues. We're going to recognize our ethical role when it comes to genetics and genomics. There is a story about a young lady that passed away that we're going to talk about when we get into genetics and genomics that I really want you all to understand. And actually ask your question, if you was a nurse back then, were those morally right to do the things that they had done to advance science today? Then we're going to recognize resources to assist in resolving ethical issues and dilemmas. So what are our values? I told you pretty much, what do you value yourself as in nursing? What do you expect to get out of nursing? And choosing the right things to do. Most of the time, people act on emotions, and sometimes they don't. They pretty much are kind of like straightforward on what they want to do when they're taking care of their clients. But you, as a nurse, you need to do a self-evaluation, kind of like what we talked about the other day, on your values and how you want to maneuver through nursing when you're taking care of your clients, especially when it comes to ethical dilemmas in nursing. Sometimes we do get put in certain situations that cause problems where we have to kind of decide, is this ethically moral for me to do? Am I going to lose my job? Am I taking care of my patients effectively? Those type of things when we're making those type of decisions. And if you have a hard time making those type of decisions, those type of decisions should not be made alone. Get with your nursing manager. Get with another set of group of peers. Get with seasoned nurses to see if they've ever been put in that type of dilemma, and ask them what are their perspectives on those type of things. So these are some of our terms that you definitely need to know. I will not be going back over them because we went over them in class, which is autonomy, beneficiary, non-malfeasance, fidelity, just, and veracity. These are the things that you will be tested on. These are board questions, and you have to know how to maneuver when you're dealing with all of these terms. All right, so what principle is most important to you? Autonomy or non-malfeasance? Yes, our patients do have the autonomy to do what they need to do as well as we. Non-malfeasance, we know we don't want to cause harm. That is the code of ethics that we take when we say our nursing vows, when we say that we're not going to harm our patients. We have to understand that we can't. Even if we make a simple mistake of giving the wrong medication, we have still caused harm because we don't know if that patient was actually allergic to that medication. It's the medication that we accidentally have given to them is going to interfere with the medication that they're currently already taking. That is very, very important. So we don't want to cause harm. Say by chance you do mess around and you do get the wrong medication. Are you going to report it? Are you going to self-report yourself? You should. If you have any kind of conscience, you should report yourself. And there are so many nurses that accidentally give medications, y'all, that is like so unreal. And they're like, oh, well, it's the same class of medicine. It's not going to do anything. You don't know that. It could be one little chemical thing that's in a medication that can cause problems with that patient that have them to react. I remember one time when I worked out at State Hospital, we had two different clients that was on Dilantin and one was on Depakote. They both are seizure medications. Both had a history of seizures. And this nurse was from HC. She was a seasoned nurse. So seasoned nurses do make mistakes. They make mistakes. And at State Hospital, the way they have the drawer set up, You set it up based off the patient and off the MAR, and you just set them up like in a little cup and put the room number or the patient initials on them or whatever like that. So every nurse have their own nick and neck on how they're going to do those type of things. Well, this season nurse, she accidentally, because both of the patients um, were in staying in the same room and it was during nighttime, and she accidentally gave each patient the opposite patient's medications. When she realized that she made that error, she came to the front because I was working the women's side that night and she was working the male side. She told me that she accidentally gave the patient the wrong medicine. She gave one patient Dilantin that should have gotten the Depakote and gave the other patient the Depakote that should have got the Dilantin. So I said, okay, well, we need to call the doctor immediately. Another seasoned nurse that worked on that unit, believe it or not, y'all, which was one of our head nurses, she said, oh, well, it doesn't matter. I mean, they both seizure medicine. And I just kind of looked at her like, it does matter. It does matter. Because with Depakote, we have to do levels. Dilantin, we don't. So it does matter. It does matter because that patient that should have got the Depakote, we got to do levels on that patient tomorrow. That levels may be skewed where it may be too high, maybe too low, and then the doctor's going to be trying to change the dose. So it does matter. And this was a seasoned nurse that was a registered nurse, and I was an LPN at the time. So that seasoned nurse that made the error, she did self-report herself. She called the doctor, told the doctor what she needed to do, and the doctor, which was kind of laid back doctor, he was like, that's okay, could just calm down. I will push that patient that should have got the Depakote levels back. I'll come right in order to say to monitor the patient. And this was like in the middle of the evening, like 6 or 7 o'clock in the evening. And that doctor came back, wrote the orders, told us what we need to do. So it kind of like be passed on to night shift and the day shift to make sure that the patient that got opposite medications did not have any issues. But that simple thing of her not self-reporting could have been something that was bad. So you kind of have to look at that too. We don't want to ever cause harm to any of our patients. We want to make sure that we don't burden anybody, making sure that because these are our licenses, like I told you all, at the end of the day, nobody can't tell you what to do because those are your licenses. So how do we make the ethical decisions? Many approach it kind of differently. What are you going to do ethically? Ethically, morally, when you be put in a certain type of situation, what are you going to do in order to take care of your client effectively and to keep your license? Because like I told you, at the end of the day, those are your license. You want to be able to keep them. Treat the patient the way if it was you lying in the bed, this is your husband, your wife, your mother, your children, your grandparents, somebody that's close to you. If that's what you do, that ethically, when you're taking care of these patients, when you're put in certain type of situations, then you would not never maneuver wrong. You would never maneuver wrong. How do I determine who's the problem? You got to know about the facts about the situation. You want to sit down, you want to analyze. That's why I kind of like teach you all how to actually listen when you're getting a report and pay attention to certain keywords when you're getting that. So you're going to be put in any kind of situation. If I know my patient is having issues with certain things, and I know that the family member is the root cause of the problem where my patient cannot get the adequate care that they need ethically and morally, I need to be reporting these things. When I'm having the round robin table with my physician and my social worker, I'm like, hey, these are the things that I feel like there's a problem that's going on with my patient. These are the things that I feel like is going wrong when the nurses, different nurses are taking care of the patient. These are the things that we need to address. These are the things that we need to make happen because we don't want the patient to be in the hospital forever. We need to be trying to get them out. We need to make sure that we're taking action and we need to be evaluating the situations that we have. You do have an ethics committee that is at every hospital. And believe it or not, you do not want to be sitting in front of the ethics committee because when you sit in front of the ethics committee, you have the board of medicine that's there that's representing the hospital. You have the board that's there that's representing the people of the hospital. Then you have a set of nurses that are going to sit there and they're going to listen to the case and say, what would a prudent nurse that's competent do in this situation? How you should have handled it. So, yes, nursing is hard. Nursing is not a walk in the cake. You have to use those judgments when you're taking care of your patient. So be mindful of that. If there's a problem, make sure that you're reporting these things so things can be handled accordingly. when we look at the resources that are available to help us with our ethical dilemma, you have several resources. The main one that we as nurses should be going by is the Code of Ethics of the ANA, which is the American Nursing Association. This code is a statement to society that outlines the values and concerns and the goals in our profession and how we need to maneuver. It should be individualized based on our personal values and our goals. This code provides a direction and it repeats the obligation and responsibility for the nurse-patient relationship and what it entails. Our next code of ethics, a nurse alludes to the ethical principle mentioned earlier, like I said, with fidelity. The patient is foremost. You need to know what those definitions mean, okay? Our school has a copy of the ANA, and I will give you all the website where you can go to get the rules. But we're going to make sure that you're ready when you get ready to sit for board so that you know what the code of ethics is of nursing so you can be ready to sit for board and understand those questions when you're being asked on board. One of the most critical things about knowing the rules is the licensure laws. Who's grant us our license? It's going to be the State Board of Nursing. That's why you do your fingerprints. That's why you do your background check. They do all of those things. And later on in the lecture, we're going to talk about some things that you all need to do on a personal level when you're working as a nurse. The Code of Ethics, which was with the ANA, was published for the Bill of Rights of Registered Nurses back in 2001. So it's not that old, but it is the first ever document rights in contrast to traditional responsibilities. So they wanted to make sure that, out of a shadow of a doubt, that nurses knew exactly what you need to do when you're in different situations, when you're dealing with different patient, clients, out there, hospice patient, med-surg patient, oncology patient, whatever it is, they have laid out the laws that we have. And even in your hospitals should have the ANA. And in fact, it's posted in the buildings. Sometimes some of the nurse managers post them in the bathroom so you do not forget what you need to be doing. I know at UNC in our bathroom, that's our reason for leisure. Read the laws. I mean, it's on there. It's on there black and white. What you're expected to know as a nurse, and what you need to be doing as a transplant nurse, and what you need to be doing just a nurse in general at UMC when you're taking care of your clients, and how you need to maneuver, who you need to be reporting to. So sometimes most nurse managers and most nurses in education, they know most people don't read anything. But if you're sitting in the bathroom, you're looking at the wall, you might as well go ahead and read it. So that's most of the time they kind of like, well, let's put it in the bathroom. Let's put it in the break room, somewhere they're going to be sitting there for long periods of time to make sure they're reading this. So there won't be no ifs, ands, or buts about what you need to know about this. Abortion. This is a big topic that pretty much drove our voting for every election since I've been able to vote since '97. This has not stopped. Okay. People want to know, when does life begin? A lot of people like to put religion in it. A lot of people like to put it at the beginning of conception or when the baby takes its first breath. Those are people's views. Whatever your view is, either it's a conception or it's when the baby takes its first breath. When you're talking to people, this is something that is so hard to talk about because people are more judgment because they like to throw the Bible in, they like to throw God in, they're like, people are going to go to hell. But you got to look at it. When most people have an abortion, why are they having it? Maybe it's because it's been of incest. Maybe it's because the baby is stillborn or has some kind of deformity and they don't want to either burden themselves, because you got to look at it. If you have a child that's born of incest, are they going to be loved properly by that parent? Because that parent is only going to remember them of being a product of incest or a product of rape. So they feel like, let me go ahead and just do this because I don't want to have no part of that. So you have to, that's that part of autonomy. We have to let that be a personal decision. And we should not put our views on it, but you're going to have so many people that are so judgmental. Like in different states now, because they've passed these abortion laws in different states because they want to be a state-by-state thing. And I'm not going to put my view in that, but there are so many women that have these babies that are stillborn. if something is in your body that is no longer viable, what is your body going to consider it as? They're going to consider it as a disease. They're going to consider it as an unwanted foreign object. And the body does what the body's going to do. It's going to try to break it down. Now we have put the mother at risk. We just had a case not too long ago. That was one of the cases they talked about on the campaign trail. Regardless if you're a Democrat or Republican, you just got to have some kind of moral incompetency where this lady she had to travel to these states or whatever like that because, she was trying to have this abortion because she had all these issues going on, and the lady ended up passing away. Same thing that was in Texas or whatever. You have a lot of doctors that have those abortion clinics because these women that are high risk that can't carry these babies because it's either the mother or it's the child or something's going on with the baby where they cannot do these abortions at all. And a lot of doctors have walked away from practice because now you're putting people that's in it that have no kind of medical affiliations. And y'all know I've talked about this for years, especially when it comes to our healthcare system, how people make decisions about our patients and about our care personally and have no kind of medical affiliation. Do you know that most nurses that try to apply for these insurance jobs that have been in the game for a long time do not get them? Because they know what needs to be done. And big insurance companies like United Healthcare or Blue Cross Blue Shield, they're not going to hire a nurse. I remember it was time before I even came to teach full time. I had applied to Blue Cross Blue Shield full time, and the first thing they asked me was how many years of nursing I had been in, and I put on there, and I did not even get a call. Versus I had a previous nursing student that was green behind the ears, that had been nursing like for 6 months. She got that job because they was able to groom her to do what they need to do. And when she actually got into it and we kind of talked about it, and she was like, Ms. Turner, I can't do this because morally I know what's right. And I can't work for a company that's going to make me lie to my patients and not cover these um, services that I know for a fact that they need because I've had a family member that was in the same dilemma. I said, well, what are you going to do? She said, I'm going to quit. And she did. So those are the things when we kind of tell you about your moral values, you kind of like have to maneuver through. All right, other things that affect us in nursing, like I said, like I believe, the code of nursing, of ethics, that is something that drives a lot of nurses to determine how they're going to maneuver with this. So I'll pull it up for you guys, and I'll put it under the module so you all can know and start ingraining it in your head so you kind of like know about the A&A code of ethics. I'm not going to like too much hard to test you on it, but I am going to test you on it. But I want you all to know so you can know exactly how serious it is when it comes to the ethical dilemmas that we as nurses be put in every day, how we're going to maneuver to take care of our clients. Sometimes we do have to sacrifice our own values, but we have to do it for the betterment of the patient. Sometimes we got to leave our thought processes behind, and we can't be judgmental because we never know what that person is dealing with, okay? All right, euthanasia. We talked about that. That's mercy killing. Back in the 80s, I know when I was growing up, I used to hear about it all the time on the news because my grandparents watched the news all the time. I used to hear about it all the time in the northern states about a certain doctor that did this, euthanasia or whatever. Back in Florida, we'll talk about that in a little bit. But it was a case where a husband and a wife were married, and that's another thing when you're looking at the ethical dilemma. You know, when you're married, you consider you're married as one, and the wife and the husband had pretty much like made the decision if she is this certain way, then they're gonna not do this part of life or whatever, and move on so she can be able to transition. And her parents were so upset and they wanted to try to sue the husband, but you can't do that. She was in her right mind when she decided these things, and they had to maneuver. And sometimes, as a parent, it's hard when your child has decided they want to end their own life, if they have maneuvered through different disease processes and they don't want the spouse to be burdened. And the mom was like, well, I could take care of my daughter. Yeah, you can, but it is a lot. It is a lot. And you have to respect those wishes as of your children. So if my kids decide to say, Mama, if this happens and I'm married and I want to maneuver through life like this, I have to accept that. Because we've sat down and we've had that conversation. They tell me how they want to maneuver or whatever. Now, if And that could be like a tricky situation too, because most parents, of course, you want your child to live because you birthed them, because you want them to live. However, you have to help them make that decision um, for them, what's best for them, and not put your feelings in it. And it's going to be hard. It's going to be very hard. Me and my mom, we've sat down and we've discussed a lot of different things too, on how I want to maneuver through if something was ever to happen to me. And it was something that was hard for her, and she had to take a pause break. We had to come back and we had to revisit that, because I don't ever want my spouse to be burdened, be able to maneuver things. That was like one of my prayers to God, like, Lord, allow me to live long enough where my kids are big enough to be able to take care of themselves, so it wouldn't be a burden on anybody. They'll be able to be self-sufficient to do all those things. And you do have a lot of parents that do wish that and pray for that, because they don't want their kids to be burdened on anybody or be put in the system or be neglected or mistreated. They want to be able to handle and maneuver accordingly. You have your durable power of attorney. In healthcare, you have your living wisdom, your advanced directives. You need to know what those are. But personally, on the level of power of attorney, I was a power of attorney over my dad's affairs when he got sick, because he really did not know how to maneuver through healthcare. He was a baby boomer. And some of you all have known when we talked about it that my uncle has been recently diagnosed with gastric cancer. And most of the doctors in Mississippi Delta, they are old, and a lot of them do not go back and get the educational resources that they need in order to take care of our clients. Some of our nurses don't either. I'm just being completely honest. I've always told you all, nursing is something that you can learn every day. I learn stuff in nursing every day, and I've been doing this almost 17 years. It'll be 17 years in August. So I've been maneuvering and learning things. So sometimes if y'all don't see me on campus, I'm probably going to be at a workshop, because I want to learn, and I want you all to do those things too when you become a nurse. You continue to learn. But these doctors and nurses at home up in the Delta, they don't do that. They get settled and complain in this unless they learn, oh, I've been doing this for years, this is where I've been trained, but nursing and medicine change every day. Long story short, how I became dual power of attorney over my dad was because he was seeing this doctor for years that did not want to refer my dad out. And me, as a nurse, I was knowing the things that he was going through medically. And I was like, no, you need to come to Jackson. You need to come to Jackson. He's like, oh, I've been seeing this doctor, blah, blah. Yeah, you've been seeing it for many moons, and you're still having the same problems. You need to come to Jackson. So finally, I decided to go get him myself, because he called me. He said that the doctor said he had Parkinson's. I said, you hadn't had Parkinson's. Anything, you probably had another stroke. Because based on the things you tell me, you could have another stroke. I don't think you've had Parkinson's. When it got him, brought him down here to Jackson, and the ER doctor told me that I got him down here Friday that he would have been dead the next day. Everything that could have gone wrong did go wrong. We tried to fix and maneuver, and God allowed us to have 18 more months with him. But prior to all of that, learned to find out that my dad had lupus. Did not know that until after the day after he had passed, because his body started shutting down again, but his baselines were normal. They didn't know what was going on. He did not have an active infection, but lupus affects everything. And Dr. Cox teaches that content. I don't know if they taught that content to y'all last semester or it'll be this semester, but whatever it is, you need to know those signs and symptoms so you'll be able to teach your patients. So they don't know, and I didn't know until after he passed that he had lupus. So moving forward with my uncle, we have decided that I'm going to be handling his affairs. My aunt has agreed to that because, once again, they're coming from the Mississippi Delta. And he was being treated for H. pylori for so long that after the third cycle of treatment for the work they've had me for GI, you know, if we getting into like the third treatment, we can't move to the maintenance drugs, and you're still on the high 3 dose drugs, which is your PPI and your 2 antibiotics, and then we need to be referred. The doctors up there did not want to refer him, and I said, absolutely not. You need to come to Jackson. And here we are. We're stage 4. And with gastric, we know that it starts with the heartburn. He said he had been treating himself for heartburn for like 3 or 4 months. Then when he went, they said they had H. pylori. H. pylori, you got to be diagnosed. You got to be diagnosed either through an EGD or through a breath test. They didn't do any of those things. They just assumed since he still had recurring GERD, there's a problem with H. pylori, put him on all those medications or whatever like that. Have been on them, and never moved to the maintenance dose of the drugs. If you have this, then it turns into gastritis, and gastritis turns into gastric cancer. So here we are, stage 4. So we went from April to December, and with long spans, and these doctors did not want to refer him out. So I'm power of attorney over all his affairs and everything, so I can make sure that he gets the adequate care that he needs to try to be transitioned to whatever it is that's going to happen. Fertility, the care of the physician, medical interventions beyond the care, what reasonable hope of benefit for the patient. Then you have your physician assisted suicide. And doctors take an oath, just like we do, is not to do any harm. Now, you guys kind of like know what we talked about with our hospice nurses, we want our patients to have to transition peacefully without any pain. And yes, in hospice they do give high doses. So it has been like an ethical dilemma that has been brought up in some states. It was like, well, we don't need any hospice nurses because they're probably overdosing the patient. If you never worked hospice, how do you know? They're only going by what's going on. If my patient is in excruciating pain, and I've already told you all the most horrifying death for our patient is going to be lung cancer because they're gasping for air. Most of those patients are going to be the ones that are going to be on hospice because that is the worst death to ever watch is your patient gasping for air, and there is nothing that you can do. There's nothing that you can do. So, yes, we're going to give them something to help them to transition over peacefully. If they're hurting, they're in pain, the hospice nurse will know how much medicine to give them. And it's only going to be the amount that the doctor has written, which you have your hospice doctor. So, yes, that's going to be an ethical dilemma that you have in certain states where they do not want hospice. So, if you know that you want to work hospice, what did I tell you how to do? Learn the rules and the regulations of every state. Learn the rules and regulations of the different policies of these facilities that you're going to be working. When you're dealing with ethical issues regarding transplant, y'all know I'm a transplant nurse all day long. Some people ask how are donors solicited. Some are voluntary. I've had a lot of people that have come in voluntarily on their own. They're very, very healthy, and they say, I want to give my kidney. I want to give my kidney, one of my kidneys. And they have to go through these long, rigorous things with a medical doctor that's in transplant to make sure that kidney is viable for them to donate. I had 4 patients that I took care of over the summer that decided to donate their kidney. And I actually took care of one of those patients. And I asked him, I said, are you donating a kidney for a family member? He's like, no. Like, young guy. He's like in his late 20s, early 30s. And I was like, well, what makes you do that? He said, because I feel like it's my duty as a Christian. If I can help save a life, I want to save a life. And he said his family had a problem with it. But he was married, and his wife didn't have a problem with it, and that was all that mattered to him. He didn't care anything about what his parents had to say or what his siblings had to say, as long as his spouse was on board, because I remember they're married as one, was okay with it, and she was very, very supportive. We taught her everything that she needs to do, the signs and symptoms, if he's having any kind of problems at home. And guess what? They have to go on anti-rejection medicine, too, because they only have one kidney that's left. But he was very, very healthy. He ate right. He was very lean. He wasn't obese. He wasn't like just skinny or anything like that. He was a healthy person, and that was his due diligence. He felt like as a Christian that he needed to do to donate their kidney to somebody. And the person that he ended up getting the kidney to was a patient that was like 2 halls over that ended up getting it. Now, granted, some people like to know and want to know who was their donor, and so happened he was still there. He didn't know who got his kidney or what like that, but the doctors knew because it was the doctor that and the patient that got the kidney was like, I want to know, who gave me this kidney. Are they still alive? And this. I want to thank them for this kidney. And so, of course, that's going to put the doctor in a dilemma. Remember, we talk about that with breaking confidentiality and stuff like that. He never told the patient that got the kidney who was there, but he did go to the patient that was still there, which was my patient, and said, the patient really want to thank the person that gave the kidney to, and you were the one that donated the kidney, or whatever. I did not tell them, but I kind of want to let you know, and let them be the ball be in your court. And he said, yes, I don't mind. He said, but I want to do it on discharge, and they did on discharge. We rolled them around there, and we let them talk to the person that he donated the kidney to. Let me make sure I didn't skip one thing, y'all. Okay. So, the next one is going to be ethical issue regarding to fetal tissue. You have a lot of babies that pass away prematurely, and most parents will donate their babies to science to try to figure out what happened, what went wrong, and that's when they do the cell stem researches and stuff like that on the embryonic um, cells or whatever like that. Um, you have a lot of people that frown on that. They're like, "Oh, that was your baby. God gave them life. You need to bury them. Why are you donating your baby to science?" And it's to make those families feel bad. Don't make those families feel bad. They've already lost a child anyway. And if it was something where their baby can benefit to make it better for another infant, then that's exactly what they're going to do. And we should not be frowning on that. But you have a lot of people that do frown on that. So I'm going to tell you about Cornetta Lex, if you don't know who she is. This is like a dilemma issue, something that happened with her. So I'm going to tell you about her story. So in 1951, she was a young mother of five, and she visited Johns Hopkins Hospital complaining of vaginal bleeding. Upon her examination, the gynecologist named Dr. Howard Jones discovered a large amount of malignant tumor cells that was in her cervix. At the time, Johns Hopkins was the only hospital that saw and treated poor African American people. So you got to look at in the 50s, there wasn't and in the 60s, there weren't a lot of places that people could go of color to get help. But Johns Hopkins was one of the hospitals. So he took care of her. She did radiation treatments for the cervical cancer. But the best medical treatment for her disease was not available at that time. So a sample of her cancer cells were retrieved during a biopsy and sent to Dr. Gray in a nearby tissue lab. So they took a biopsy of her tissues without her knowing, without her permission, because granted, this is the only hospital that can take care of poor African American people and women at the time. So these cells were taken without her permission. And upon the researching it, her cells were given to other patients, collected from all other patients, regardless of their race, socioeconomic status. So what they did, people of different races, they were doing biopsies, but it was something special about her cells. When they were doing it, Dr. Gates realized that her cells never died like the other races, like of women and Asian and other kind of descent. Her cells never died. Her cells actually doubled every 20 to 24 hours. Okay, so their cells now are known as HeLa cells, and those cells are used to do many, many things to study the effects on different toxins, drugs, hormones, and viruses, and on growth of the different types of cancer. So these cells have generated so many cells in 24 hours that they have so many cells now, y'all, to do research on to actually help. Believe it or not, when they used her cells in order to come up with the polio vaccine and to even help the effects of the COVID virus to come up with that type of vaccine. So she ultimately passed October 1951. She was only 31 years old, and her cells still impact how we use science today because her cells never died. So you're looking at she passed away at the age of 31 in 1951. Here we are sitting at 2024, and they're still using her cells to research and do cancer. Now, with that being said, ethically, do you all think that was right for them to take her cells to do that? And legally, do you all think they could do that? So those are two questions I'm posing to you all. And I'm going to open up a discussion board, and I want to hear your thoughts on it outside of your case study homework that we're going to have. So I make sure that you understand this chapter. But those are two things that drive science. And the family they end up suing because you're using her cells without her permission. So ethically and morally, was it right? And you got to look at the times that they were in the 1950s, and this was the only hospital that could take care of women of color. And legally, did they have a leg to stand on to do that? Now, granted, I do not want you to research this in depth. I just want you to answer those two questions. We'll be completely honest. When I open up this forum for you all to discuss this, we're going to be cordial to our classmates. Do not put personal beliefs in. I want you to answer as a nurse, morally, legally. Did Johns Hopkins have a right to do this? And what are your stance on it? Okay? We're not going to argue in the discussion board. If I feel like we're going to argue, we're going to shut it down. We got to be able to respect everybody's opinion. We're going to agree to disagree on a lot of things. But I just want to know what your thoughts are about this, okay? Okay. All right. In vitro fertilization. A lot of people have a problem with that. They call them designer babies. They're not. They're not. A lot of people have a hard time carrying babies. You have a lot of women that are high risk. They cannot carry them. And yes, it is expensive. It's expensive not only on the mother's part because she got to take all these hormonal injections, but sometimes the dad may have to take some injections too. So it can be very costly, especially if it does not stick or take the first time. A lot of people feel like, oh, God gave you the resources to be able to have these babies on your own. Yeah, He did. However, some women have a hard time carrying or even having a baby. You don't never know until you try. All right. A lot of people have an issue like should they pick their baby's gender or whatever like that. Like you don't know how hard it may have been on that family to try to have a baby on their own. The reason why they was able to do this. I remember I have one of my clients that I took care of. They when he got diagnosed, they harvested sperm cells, and so they before he had treatment to make sure he'd be able to carry a baby once he finished his treatment. So they did, and their first baby was in vitro because they had to harvest the cells. So they was content they was able to have this baby or whatever like that, and you all would not believe it. It was like 18 months after they had that baby, they were able to conceive on their own. It was a shock to both of them because of the chemo that we gave them, which is adriamycin, some hard chemo. They felt like they weren't be able to have any kids anymore. So that's content with the ones they had. And they were able to have this baby naturally. And they was a set of twins. So they had a girl and they had a boy. And they were blessed with it. So they have the oldest daughter and then they have those set of twins that they were able to have on their own. People want to know limited only to heterosexual marriage couples. You have a lot of people now that do have babies. They may ask for a donor, and they may be the same sex. Maybe you have two women that are married or whatever like that, and they ask for a donor. People frown on that. Well, oh, if you want to have a baby, then you should have stayed married to a man or got with a man. Why are you with a woman that's gonna make the baby confused and all those type of things? Those are ethical and moral dilemmas that you all are going to deal with in nursing. If you know your values and you do a self-evaluation, if you know you can't take care of those type of clients, then that's not the type of nursing that you need to do. You need to maneuver on and do something else. Then you have some where you have two men that may be married and they may have a surrogate and they want to have kids and they go, oh, well, then you should have been married to a woman. So it's going to be vice versa. Those are the things that you're going to be dealing with in your nursing career. You have to do that self-evaluation. Can you do this? Can you take care of these type of patients that decide to do in vitro or have a surrogate or be of the same sex or opposite sex or whatever it is that they're doing? Are you ethically moral? Can you take care of these clients without being judgmental? What are genetics and what are genomics? Everybody we know what genetics is. Genetics is the study of how what we get and what we inherit from our people, from our parents. We get like so many chromosomes from our dad, so many chromosomes from our mother, and we become that person. We become that person. Like you have some say, oh my God, you look just like your mom. Oh my God, you look just like your dad. Oh my God, you look like both of your parents. It just depends on what it's going to be, what God says you're going to be when you come out. Then you got to look at the genomics, and that's just a study of all the person's genes that the person's going to have within the environment. All right, what is our nurse's role? I told you guys, we got to be educated. Education is the key. Do not be letting stuff come out your mouth that does not make sense. You're going to have people that's going to come in and just try to challenge your degree, challenge your knowledge. If you know what you know, you know what you know. And that's just the way it is. That's why you have to learn. If you know that you want to work in research with genetics or genetic testing, get that certification. Know what you know. So you can be informed and educated when you're educating these patients, when you're helping them. And sometimes, believe it or not, we have to educate our doctors. They learn just as well as we do. Don't let anybody ever tell you that you don't know what you know, because you do know. All right, Tay-Sachs disease and cystic fibrosis. You got to look at that. That's a genetic disease, and you got to look at who it affects the most. Tay-Sachs, you're going to see it more in your Asian descent. Cystic fibrosis, you're going to see it more in your Caucasian descent, or you're going to see it in your patients of mixed race, because it's just a genetic disease. What you're going to see mostly genetically in African Americans is going to be sickle cell. That's pretty much what you're going to see. If you have a mixed race, where you have like a white parent or a black parent, if it's so strong in that family line, that they may be a carrier of it, but it's just genetic makeup of your patient. You may detect different female disorders. You all learned about the abnormalities in mother baby, so we're not going to go over that. But you do need to know certain genetics, what disease affect different races. So if I'm taking care of a patient of Asian descent and they're coming in with all these signs and symptoms, and I'm like, that sounds like you may have Tay-Sachs, guess what I'm going to do? I'm going to go look it up. If I'm not for sure, if I got a good feeling they having something that I know for a fact that no other race have come in with or complain of, most likely it's going to be Tay-Sachs disease. Cystic fibrosis, those are the things that y'all have learned. You got to know those things, okay? You got to know. So like I said, with Tay-Sachs, like if they come from the different regions, like of East Asian, South Asian, or South Asian areas, those type of descents, they're going to have that disorder. So you need to know the signs and symptoms of that and what's causing it, because it is a genetic disease disorder. Okay, and they've had said that some European descents can also have it too. So you got to look at that population area of Asia and the European descent, those type of patients that's going to have the Tay-Sachs, okay? All right. Do all individuals merit the same type of care? They should. Ethically and morally, we should treat everybody the same when we're taking care of them, regardless of race, regardless of gender background, regardless of economic status. We should teach everybody the same. Does healthcare and insurance decides how we're going to treat them? It does. It does. And I'm going to give you an example. I work at Baptist, and you have your oncology department, and you have the hospital outpatient. If you have government assistance like Medicare, Medicaid, or anything like that, or no money at all, guess where those patients go? They go upstairs to outpatient, because the hospital is going to help them find financial assistance to do that. But if you have private insurance, you get your treatment at the doctor's office. I remember one year I had been working at outpatient maybe about 2 years, and because I had maneuvered from the floor, and I had a patient. She had private insurance, so she was getting her chemo down in the doctor's office. So it was like, oh, if you get your treatment down here in the doctor's office, that's the be all of be all. It's not. It's really not. I mean, your care is going to be the same regardless if you're upstairs or downstairs. Where she lost her insurance because her husband lost his job. So she didn't have any insurance, so she had to come to outpatient, and she was so bitter at first, because she's like, and I don't have any insurance, and I gotta come up here and get my chemo. And I kind of like looked at her like, really? So you think because you're not the doctor's office, you're not gonna get the same level of care? And so as we treated her, so about the third treatment, she apologized to us, and she was like, actually, I get better care up here than I do down there, because I get a warm blanket up here, I get a lunch. My husband don't have to go out and try to figure out what to get me to eat. You all like make sure that I do this. You all check on me more than they did downstairs. But in her perception, she felt like because she wasn't at the doctor's office anymore, her level of care was not going to be the same. And it was, and it was even better. Okay, so what impacts does social media have and social networking on nursing practice? Y'all, let me explain something to you. Go through and clean your social media accounts up. Yeah, some of y'all, you know who you were. I don't have to say any names, but we had this conversation in class, and you all was like, Miss Turner, I see you on Facebook. You can't find me on Facebook. I was like, believe it or not, y'all do pop up on my stuff, because I have a mutual friend of a mutual friend of somebody y'all know. For some reason, Facebook, they feel like I know y'all, so y'all tend to pop up on my stuff. And I told you guys that you cannot be friends with any of us until after you walk across the stage. With that being said, if a job wants to find out something about you, they're going to find out about you because they have savvy tech people that have stuff all day long. I don't care if you have your stuff set to private. They're going to find out something about you. So this is the time that you need to go through and clean up your social media accounts. Social media is going to be the death of some of you all, and it's going to be the death of some of you all not getting jobs. Because of something that you may have put on there when you was 15 years old, where some of y'all was lying and saying that y'all was 18 years old to get an account, you better go back from the time you first opened up your account and clean your stuff out. Because believe it, those are things that they want to know, is this a person that I can trust to work for my company? Go through and clean your stuff out. If you're angry about something, vent to yourself, vent out in public. Put that stuff on social media. It don't take 2 seconds for somebody to screenshot something, and it could be very well your friend. Like me and my husband used to always tell my kids, and he still tell my kids, y'all don't have friends, you have associates. Okay, you have to be mindful of people that you allow to be in your space on your social media platforms, because those will be the ones that will allow you to not be to have a job. So go through and clean your stuff out. Look through your stuff, because there is a way that people can look through your stuff to find out if you are a potential employee that they want for their company. You have been the top student in our class with a 4.0, but if your social media account is raunchy, it's all outside, they will not hire you. And I'm sorry, it is what it is. And I've told y'all from day one, clean your stuff up. Y'all have, some of y'all have had me since day one, first one. I've always told y'all I appreciate y'all. Clean your stuff up. Make sure your social media platforms are viable, or just shut the whole platform down and be done. All right, guidelines to social media. Recall what you have is ethical dilemma. We just talked about that. Make sure you don't have videos, images, and stuff like that. That's going to expose you. Please, y'all, whatever you do, if you want to take pictures of yourself and you work for XYZ hospital, take your badges off. Take them off. You lose your job all day long. Don't be sitting at the desk snapping it up. Don't be on the elevator snapping it up. If you're sitting in your personal vehicle taking a picture, that's your personal vehicle. You're not inside the vehicle. Because when you start taking pictures inside of the facility with your stuff on, that means that's property of the hospital, believe it or not. And the hospital can actually sue you for that. If you don't believe me, ask somebody. I'm just telling you. When we take pictures at the hospital, and we're there, it's normally the representative of the hospital that's taking the picture, and they'll send it to me because they have ownership of their pictures. Sometimes they use it in their bulletin or whatever. The last couple times we've gone to Baptist and they've taken pictures of us, we've been on Baptist website. Now, granted, if you take that picture from the Baptist website and put it on your platform, that is fine. That's naturally fine because it was somebody at that hospital that did it. But don't be snapping it up in the cafeteria, doing all these things. That's why I take your phones. I don't share your phones because I want you to get a job. It is what it is. I mean, I can't speak for any other instructor, but I collect phones because I want you to be able to have a job at least while you're with me in clinicals. Now, when you leave clinicals and you want to snap it up and you get in trouble, hey, that's on you. I can't say it at that point. But I make you take your badges off, take your tops off, and all those things so you won't get in trouble. Do not disclose any information about anybody, patient, race, or age, race. That's why I tell you all when y'all finish your stuff for doctor care to bring it to me so I can shred it. Because I'm responsible for that stuff because, like I told you guys, y'all are on my license. I ask you for stuff, and most of the time I tell y'all, go ahead and put your stuff in doctor care, the majority of what you have, so it won't be a whole lot that you have to do. And if you're done with all your stuff, you can put the stuff in the shred box while we're there at the hospital, and you won't have that problem. We don't talk about patient information on the elevators. It's on a need-to-know basis, and please do not discuss any of the patients that you take care of with family members. I know it is so hard to do, y'all, but please don't do that. That's why we have post-conference, because that person that you're talking about, and if you're at home talking to grandmama may know that, may be talking to somebody else, and that person that grandmama talking to may know that person that you're talking about. And guess what? You're a broken hipper, and I got to write you up, especially if it comes back on us that you were the ones that told that person that was in the hospital. So please be mindful of that. Same thing with social media. You can't be doing any harassment, profanity, hostility, all of those things. I don't have to go there with y'all. Y'all know what you can and you can't do. And the privacy for breach of confidentiality and all of those things. And I'm also here where it's the data national council state. I'm gonna post all these things for you all, for the guidelines for your reading pleasure, because back in 2011, that's when social media started kicking up with people and nurses started losing their jobs. So on the module, I will give those rules and regulations to y'all about the code of ethics, and on this one, so you can have it for your reading pleasure. So when we get ready to go to the State Board of Nursing, and somebody there is getting in trouble for that, you know why they got in trouble. This is your case study homework. This homework will be due on Sunday at noon. That's going to give you all enough time to read the chapters and to be able to answer these questions accordingly. So this is your case study. I'm not going to read it to you, but there is 6 questions at the end that you have to answer. The discussion board I'm going to open up on Friday, which is today, as I'm recording this lecture for you. And the discussion board, I'm going to shut it down on Sunday also at noon. All right? So these are your 6 questions that we have to do. So just read your chapters. Everything is due Sunday at noon. So it's going to give you all day Friday and all day Saturday and Sunday to get this done, and you should be good. If you have any questions, you all know that you all can shoot me an email, and I will try to answer your questions as I can, but make sure you have read the chapters first before you answer or email me for anything. All right, and I'll see you guys next week.